our second webinar in the ONTPD series, How to Build a POCUS Program. Today, we will be focusing on curriculum development, and we're very excited to be welcoming our primary speaker, Dr. Stephanie Marshall. Dr. Marshall is an assistant professor of pediatrics at the Northwestern University Feinberg School of Medicine and an attending neonatologist at Lurie Children's Hospital. She is the faculty lead for neonatal critical care point of care ultrasound with a focus on medical education. She developed the innovative POCUS curriculum used at Lurie Children's Hospital. Dr. Marshall is an active participant in POCUS education on a national level and is involved in several ongoing point of care ultrasound research projects. And with that, I'll let Dr. Marshall take it away.
Good afternoon, everyone, and Happy New Year to all. Again, my name is Dr. Stephanie Marshall. I'm from Ann and Robert H. Lurie Children's Hospital. And today I want to welcome you to ONTPD Presents How to Build a POCUS Program, again, with a focus on curriculum development. I don't have any disclosures. Our learning objectives for today are to, one, understand the fundamentals of curriculum design, and to relate those fundamentals to point of care ultrasound. So if you weren't able to attend the initial webinar, you can find it on YouTube under ONTPD Presents How to Build a POCUS Program by Dr. Maki Fraga on program development. So I'm going to start with just an overview of curriculum development, and this is essentially based on the book Curriculum Development for Medical Education, and this is the foundation that we use to kickstart our curriculum at Lurie Children's. And there are 6 steps identified in this curriculum, with step 1 being problem identification. This is the key first step in curriculum design and development. And the ultimate purpose of problem identification is to equip your learners to address a problem affecting a given population. And this is accomplished through a variety of additional steps, mostly maintained with a well-focused review of information that is already available, including journal articles, medical literature, webinars such as this one, and additional courses. And questions that are asked during this problem identification step include who the problem affects. Does it affect people with a particular disease or society at large? And in our population, we are focusing on the neonatal population. And then what does the problem affect? Does it affect their clinical outcomes, their quality of life, the use of healthcare and other resources? And then finally, what is currently being done? How are healthcare professionals currently addressing the problem to avoid reinventing the wheel? So there are various opportunities for ultrasound foundational education and hands-on training that are done nationally, including these listed here, just to name a few. And I put these here mainly because they were important into the kickstart that we had here. And those include Children's Hospital of Philadelphia, who offer a 2-day course twice a year. The emergency ultrasound course by Third Rock Ultrasound, they offer what's called an import course, and that's something that we took advantage of, where they will send a couple of ultrasound educators to your location and to your hospital, and complete a full day of didactic and hands-on training at your hospital with models that are provided either by them for a fee, or you can provide the models as well. And then Society of Critical Care Medicine also offers a couple of ultrasound courses each year. Additionally, there are workshops available at a national level through the AAP National Conference and through PAS. At Lurie Children's, point of care ultrasound was utilized readily in the ER and the PICU, with no utilization in the NICU aside from the occasional bladder scan use. After the initial problem identification through journal review, I utilized the CHOP course as my foundational introduction to point of care ultrasound. And And of course, after these courses, you just get overwhelmed with excitement and you want to ultrasound everyone. But taking a step back, I had a lot of discussions with our radiology department, including the director of ultrasound and the director of interventional radiology, as well as our cardiology department, regarding our plans for development of a point of care ultrasound program within the NICU, just to get their thoughts and ideas on how we can ensure quality assurance and have attainable goals in terms of image acquisition and image interpretation, so that our group can better understand what we are getting involved in. And through ultrasound and IR, I was actually led in the direction of Dr. Russ Horowitz. He is the director of point of care ultrasound within the Lurie ER, and he's the only physician that is credentialed in point of care ultrasound in the Lurie system when we first started this program. And through him, I found a lot more education and oversight. And with his guidance and direction, my image acquisition and interpretation skills developed immensely to the point of credentialing. And this is where we began our journey. And because no one can, sorry, you can go back to that. Because no one can do this alone, I found a partnership in my colleagues and co-developers of our POCUS program, Cassandra Montoya, who is NICU based, and Sean Sen, who is NICU and cardiology based, both trained in different aspects of point of care ultrasound. And from here, we proceeded with the remainder of our steps. The next step is completing a targeted needs assessment. So this is the process by which the curriculum developer applies the knowledge gained from the problem identification step to their learners and learning environment. The goal of this is to better understand their learners and learning environment in order to develop a curriculum that best suits their needs and addresses the identified healthcare problem from step one. Thank you. A targeted needs assessment can be formal, so questionnaires or surveys, or informal in addressing things specific to your unit. The first is understanding the targeted learners. So who are they? In most NICUs, in our NICU specifically, we have nurse practitioners, we have our fellows, we have residents and students. And you want to identify the group that is most likely with further education to contribute to the solution of the problem. At Lurie, we targeted the neonatal perinatal fellows, as fellows are more readily malleable regarding their education, in that they have dedicated education time as well as a slightly more flexible schedule, and they can further the utilization of point of care ultrasound in their next journey after fellowship. Additionally, what is your primary focus and what will your scope of practice be? And lastly, where will the curriculum occur, which we'll discuss later. So in the first webinar of the series, it was just developing your scope of practice as a portion of building your foundation was discussed. And I will reiterate a couple of things here. So one, determining procedural versus diagnostic. The use of point of care ultrasound in a procedural manner requires competency. We are all credentialed and highly skilled in these procedures, including arterial lines, PIVs, PICC lines, and lumbar punctures. And we are adding a tool to this already known procedure. So for procedural-based ultrasound, we are building competency with using ultrasound for this procedure that you already know. Versus diagnostic evaluations that can, one, change clinical management, can change what you're doing with the patient. This requires further credentialing. And then number two, what will benefit your unit the most? At my institution, we completed an informal targeted assessment and saw that there was a slight increase in umbilical venous line related pericardial effusions, an increased number of attempts for different procedures, including art lines, PICC lines, and lumbar punctures. And based on this assessment, we targeted procedural as the primary focus of the curriculum, while simultaneously developing our skills on a diagnostic level. We also do some bedside lung and cardiac evaluations, looking at pneumothoraces and pleural effusions, pericardial effusions, and qualitative function with our fellows. And then what framework is in place? So at Lurie, we have identified our VAT team, which is our vascular access team, and they go throughout the hospital for IV placement. And we have our interventional radiologists who do a lot of the PICC lines if we aren't able to obtain it on the unit, and will place arterial lines for us if we need them, and also will complete some LPs if they're unable to be obtained. In step 3, once your needs have been identified, it's time to address those needs by developing goals and objectives. The main goal of this step is to define and provide focus to your curriculum. These steps will help direct the choice of curriculum content, help suggest what learning methods would be the most effective, and provides a clear communication about what the curriculum addresses and hopes to achieve. This slide here shows a big Bloom's taxonomy, which is the framework for categorizing educational goals. This framework helps create an organization to the objectives and ensure that the instruction and assessment are aligned with the objectives. This is the framework for which our goals and objectives were developed. So I just placed here a couple of examples of our goals and objectives for our curriculum. And based on the Bloom's taxonomy, using a lot of action words to identify what you expect your learners to get out of this educational session or curriculum. So for ours, there are a couple of other ones, but I put at least the basics and knobology section. And by the end of this educational session or curriculum, we want our learners to complete these 8 steps. And for vascular access and LP, same thing. By the end of our curriculum, we expect our learners to have completed these steps to fully understand point of care ultrasound in these aspects. And once your goals and specific measurable objectives for a curriculum have been determined, the next step is to develop the educational strategies by which those objectives will be achieved. In this section, I am combining steps 4 and 5, as I think the educational strategies and implementation of those strategies as all-encompassing. So in educational strategies, these provide a means by which the curriculum's objectives are achieved. In a POCUS program, lectures alone are not sufficient. Hands-on time alone may not be sufficient. Creating a list of strategies that are feasible to accomplish and fitting in line with the curriculum's objectives is the key first step. This is more than likely to include multiple modes for achievement, so a combination of lectures and hands-on. These strategies are not written in stone and are subject to be adjusted, removed, or ongoing based on your evaluation and feedback. And implementation includes identification of resources, obtaining support, and finally piloting your curriculum. So I'm going to talk about our strategy. And I split up our strategy in a knowledge-based strategy and a procedural-based strategy. One of the forefront for the knowledge-based are lectures and didactics. This is important to the foundational knowledge of ultrasound. Our program started about 2 to 2.5 years ago, and we have changed our lecture delivery at least once, with more changes likely to come. In our first round of implementation, we provided 4 lectures, 4 one-hour-long lectures within the first 3 to 4 months of the academic year. During our mandatory fellow lectures. We quickly found that the information was not sticking as well as we would hope, since it was not immediately followed up by a hands-on session where those technical skills could be practiced immediately after hearing the information. Our second round, we secured dedicated time, so a full day during the first year orientation week, to provide all the didactics and some hands-on practice in our own little point of care ultrasound boot camp. And upcoming, I'm hoping either this year or the next year, but it's still in planning, a combined boot camp with our ER and PICU fellows so that we can share resources, share what we know, and have a more cohesive approach to point of care ultrasound. Second, in looking at image reviews and case presentations, we did these again. These have changed a couple of times already. In our first round, we did monthly review of images in person and virtually, during which the fellows talked through images and described how they were obtained, including which probe they used, where the probe was in position on the body, and then they interpret those images. And this helped a lot with just image interpretation skills. But because the curriculum is not, for us at least, is not mandatory and couldn't occur during the fellow conference time, the attendance was suboptimal. So this time around, we tried something new starting last year, which was a combined case presentation and image review through text messages. In these text messages, the fellows, it's one big group chain or text chain that includes our fellows. It includes a few stakeholder faculty members. And during these text chains or text messages, the fellows are given a case, a clinical case with a couple of questions that they have to answer. And a lot of these cases include the fellows working through the clinical scenario and determining exactly what they want to look for from an ultrasound perspective. So once they talk through the case, they then can start to ask for specific images. And if they were to ask for a lung image, they would let me know what probe they want to use, how they would approach the lung exam for this case presentation. And then I will provide them with images and they can interpret those. And same if they wanted cardiac, they would tell me the probe, tell me the position on the body, and interpret the image that they were given. One of the things that this allows is the fellows can participate from anywhere. They can be in the store, they can be at home, they can be on the unit with a little bit of downtime, and they can still participate. Also, these occur about an hour before their fellow lectures, so they're already in the educational mindset. And they can refer back to the text chain for any images that they want to review, or if they just wanted a refresher. And then I added a few apps and websites that I use very regularly when looking at images, including Neocardio Lab, the POCUS Atlas, the Emergency Ultrasound Handbook, and NICU POCUS. And the last thing that added to just the knowledge portion was creating a PDF for the learners with just some tips and tricks to approaching different point of care ultrasound evaluations, including vascular access, LP, with images to refer to when they are looking through those, working through obtaining those images, and then how to care for the machine, how to clean the machine, and tips and tricks to ultrasounding just in our unit specifically. And next, strategizing about the hands-on practice. So I added the logos for my two hospitals because we utilize our patients for practice. The fellows are encouraged to practice their skills during their service time, as well as on-call time if the unit allows. I've personally made it a habit to do general ultrasounds on babies that are admitted to the unit if they're stable as part of my exam. And the fellows always join for those ultrasound practice sessions and will get some practice in themselves. The fellows also will make a new test patient, which with each of their exams include their initials so that they can go back, retrieve those specific images, and obtain feedback on every single image that they obtain. They all receive a USB at the start of fellowship that is used to house all of their ultrasound scans for later review and feedback. If they are scanning and would like real-time feedback, they are encouraged to call via FaceTime or video chat for an in-the-moment review of their scan and real-time guidance. This is an offer that has been taken up by quite a few fellows, even after they have graduated. Lastly, the fellow procedure log that is completed on an electronic platform was amended to include ultrasound-guided procedures to be used as a competency measure once they have graduated. But because you're not able to always use the unit or practice certain skills without a necessity, we have also utilized additional simulators. So we have SonoSim, which is a computer simulated cases and simulated procedural practice. Most of the cases on SonoSim are adult and older children, but certain aspects of point of care ultrasound do translate down to our neonatal population, including lung evaluations, cardiac evaluations, and some of the vascular access checks. They are working on incorporating more neonatal specific cases and have so far added head ultrasound and IVH as part of their case scenarios. We do have a few of these SonoSim kits that the fellows can take home on loan for additional practice. And lastly, here we have the Blue Phantom, which is a vascular block with 4 vessels that allow for real-time practice of vascular access. While it doesn't account for the movement that inevitably occurs in the neonate, it allows for the practice of the techniques required to access the veins and arteries. I added an image here, a slide here, just about our POCUS bootcamp from this past year. So in this first, the bigger picture, you see some of our faculty members and fellows that are participating in vascular access. And we actually encourage them to look at each other's arteries and veins to help distinguish artery versus vein on ultrasound and go through all of the techniques and competencies related to that. And then they practice on the Blue Phantom afterwards with actual needles. On the side with the 3 pictures, we have a fellow practicing with the Blue Phantom. In the second picture, we have lung ultrasounds via SonoSim. And then in the final picture, we have cardiac evaluations with the SonoSim. So the next few slides, I actually included an example of one of our text presentations that I didn't include all of the discussion that occurs in between, but this is just a little snapshot of what we include in these text chains. And for this one, we had a 35-weeker with a prenatal history of prolonged oligohydramnios that developed severe respiratory failure requiring the oscillator, and then had further decompensation. So the questions that they had to answer were, what is your differential? Based on the likely diagnosis, what are you concerned about with his sudden decompensation? And how will you evaluate this via ultrasound? All of them quickly went to pneumothoraces as the biggest concern. So then we walk through how to evaluate for the pneumothorax, looking at a scanning protocol. Sorry, Rachel, you can go to the next slide. Looking at the scanning protocol, these are some images that I received from the ultrasound handbook app. And then I will provide real-time videos that occurred on the unit. 2 of them here. One is an example of a pneumothorax, just an absent lung sliding, and the second video is an example of the lung point associated with a pneumothorax. You can go to the next slide, sorry. And then finally, looking at other modes that can help with the identification of pneumothoraces, and providing those images so that they can come back to this at any time and review these images and review this information. And then they're left with some learning points at the end. And then finally, your evaluation and feedback. We really encourage the fellows to provide feedback throughout the year, as this is going to be the basis of how we progress the program with the years to come. And we also add, of course, surveys in the beginning of the year, just to get an idea of where the fellows are sitting for their ultrasound education, and at the end of the year to give us a better idea of if there's anything that needs to change for the next time. Again, these are the 6 steps that we just went through for curriculum development of medical education. Thank you so much for your time. And if you have any questions, feel free to put them in the chat and we can answer them through our question and answer session.
Thank you so much, Dr. Marshall, for that excellent presentation. We'll be putting some information in the chat for you. In terms of sending your specific questions, you can send them out to me, Karina Lawrence, or Kara Beth Carr, and we'll filter them to the expert panel for you. So first question is for Dr. Marshall. Question is, would love to hear about the cases you use on SonoSim. I have SonoSim, but haven't started, as they all seem more appropriate for adults.
So the majority of them are very appropriate for adults. The main things that we use on the SonoSim are looking at the 4 basic views of cardiac evaluation. So looking at the subcostal views, the peristernal long, peristernal short, and the axillary views. We're not necessarily looking at PDA structures because that's not one of our scope of practices that we have maintained in our curriculum, but just getting a better practice of the 4 basic views of ultrasound, looking at pericardial effusions in a lot of these scans, and those still translate down into the neonatal population, as well as doing lung ultrasounds, looking at lung sliding, looking at pleural effusions, loculated pleural effusions, basic or simple effusions. And a lot of those will also correlate in the neonatal population by looking at fluid in certain areas. A lot of the other ones we don't use as part of our curriculum, but they're there if they really want to play with things. And there are definitely other simulators available and around that others may have more experience with.
Our next question for the panel is, how do you assess competency for individual providers?
So I can answer how we are doing ours. In terms of procedural competency, we are doing a lot on, the fellows will watch as we do the procedures with ultrasound guidance. And then we will observe their procedural guidance and offer them tips during that time. And once they have been deemed competent, we're essentially using about 20 procedures in each section to gain competency. But that number is essentially just coming from our ER, and that's what they use for their fellows. So we're using the same thing.
Our next question is, we've had some pushback from cardiology about CV exams, documentation of scans, EMR reports, and billing. Are we in competition with them?
So we don't bill for our cardiac evaluations. They're essentially just quick bedside checks, mainly because I'm the only one in the NICU that's credentialed for the diagnostic evaluations. So we don't bill for them. We just use it as a quick check before getting an official echo. But others that do a lot more hemodynamics may have a lot more information about that one.
Yeah, I was going to say that. So one of the most important things, so you don't get pushback from cardiology, is really communicate what your goals are, what we are developing this kind of program, what we're going to be looking for, why is it helpful for us. So in our case at CHOP, we do bill for echoes, but it's totally different from cardiology, right? Because the billing is different. We bill for focused echoes, not for structural and complete. And the rule we have is that we cannot bill for 2 echoes a day. So if cardiology does an echo on a patient, then for that day, if we have point of care ultrasounds done, we don't bill for that, right? So that way we avoid any miscommunication or misunderstanding. I think Alan wants to talk.
Alan always wants to talk.
Hand raise, yeah, go ahead.
Thank you, sir. I was muted for the last one as well, so I want to make a brief comment about both. The comment about in competition with cardiology, I think is unfortunate if it ever comes across that way. We really aren't. These are additional scans with focused indications. I am not ever doing a full scan for a structural assessment. That's the cardiologist's job. And at present, where I am in Austin, we're not even doing more complex focused hemodynamic assessments of PDA or PPHN. The cardiologists want to do those too. And that's fine, as long as they'll come every time I call. I'm delighted for them to do that. But in the 25-weeker who collapses in a code situation where I think they might have a pericardial effusion, or I want to know how much fluid resuscitation to give them, then the cardiologist isn't going to be here in time. I'm doing a much more focused assessment. And yeah, I'm going to bill a 99308 for that as a focused cardiac exam that I'm going to bill once. That's all been approved through the AAP. I am actually a pediatrics Mednax employee. That's gone through our billing regimen. David Cantor sits at the head of that within the AAP and within Mednax. So this is very well thought out in terms of what we should and shouldn't bill for. I wanted to just add on to Karina Lawrence's comment about the scans required to be competent. That's definitely a key part of it. I just want to add on 2 other things that I think are helpful. We should all be doing regular quality improvement sessions where we view each other's scans so that we have outside influence to look for that, to make sure that people aren't working in isolation and not able to get feedback. We do that for everything else we do. So point of care ultrasound should be part of that too. One thing I also have sort of imported from the European training structure for this is the mini CEX, a mini case-based examination essentially. So whenever all of our trainees or practitioners have finished the appropriate number of scans and done the appropriate number of didactics, we also do a directly observed scan with them where we make sure that, as you can see on the screen here, they've come up with the correct indication for the POCUS. They've done all the things in terms of the, sterilization, being gentle with the baby, looking out for cardiorespiratory status, all the things around the scan, as well as the actual components of the scan itself. And I personally, because of my control freakery, find it really helpful to know that not just has one of my trainees done X number of scans, but they've also done a directly supervised scan with the person that makes sure they've done everything. And then the month after that, I know I'm going to see a few of their scans at the monthly QI meeting to make sure they're doing what I hoped they were doing.
To piggyback a little off of what Alan's saying there, from a competency standpoint, we had a certain number of exams that people had to complete. For example, for a diagnostic, we did 25 lung, 25 line. But it's not just the number, it's really how competent are they. So I think Alan's thought of having them do many and then visualizing how they do it or see how they do it is a great consideration. We also asked our fellows to attend at least 2 of the QI sessions per year. We should really probably do more than that, but it gives them, as Stephanie mentioned, an opportunity to go over their studies for us to see what they're doing and how they're interpreting. And so we ask our fellows to do that each year as well.
The next question is, when planning on starting a POCUS program where no one on the staff has an ultrasound background, what would be the first step?
Easy, look for help. So there is always someone in the institution that either has is using ultrasound or came from another institution, credentialed already, or came from another country already, doing this. It doesn't have to be in your specialty, right? You can go out to critical care, to the emergency department, and expand from that, and get help from radiology, get help from cardiology. You can learn from them a lot. So if you don't have anyone at your institution that can help you, then you have to start to train yourself, right? And go take courses, see if you can join other hospitals, for rotations where, you can learn more of this. And I think that's the very beginning, but I bet there is always someone who has ultrasound knowledge clinically, not in radiology. But if you don't have anyone, then go to radiology and ask for help. That's my advice.
I really like this paper from Jay Kim in Cincinnati, who absolutely echoes what Mackie has said, but he breaks it down into the sort of steps for that. So I think this is a wonderful pragmatic guide in terms of more like a kindly mentorship uncle kind of advice, where he basically says, work out what you would really like to do. Use your interdepartmental collaboration. As Mackie says, there's got to be somebody in the building that knows how to do this. Use your didactics and your simulations. Target your high yield applications first. I think this is really key. And having spent a bit of time trying to roll out POCUS for umbilical lines, I'm reinvigorating our program here in Austin for PIVs, PALs, and heart rate in the delivery room, because I think they're higher yield and easier starter applications. I think the same for lung. Actually, I wish I was better at lung imaging. I would do more lung if I had that skill set. Our PICU guys are going to help us with that. But yeah, pick some high yield applications rather than thinking you can roll out a full application for every indication. That's too many people being trained to do too many things. And then once you've done one thing right, celebrate that, show everybody the benefit of that, and jump on to the next step after that.
The next question is, for central line vascular access, do you require your fellows to complete a specific number of lines successfully before giving them privileges to do them on their own?
Not sure that's a POCUS question. I think that might be our procedural fellowship question.
Yeah, but remember that fellows always practice under supervision, right? Always throughout. I mean, Karina, you can speak more since you are the fellowship director there, but so they're never doing this alone. So at CHOP, we teach them how to do lines guided by ultrasound, and of course we are usually with them. When they become good, they do it themselves, but they're always supervised. You have to co-sign the procedure and all that. So, right.
Yeah, and I think the question of competency and readiness for independence is kind of a moving target, right? It's a very individualized target. So whereas maybe one learner needs to do 5 lines in order to become fully independent, maybe another one needs to do like 7, 8, 9, 10. So we use an entrustable professional activity style sort of assessment here for readiness for degrees of independence. So I think the short answer is that I don't think there is a one size fits all specific number, but rather an individualized sort of hierarchy or gradation of independence that you give your learners based upon the skills that they've demonstrated.
What are some of the ways that you have found to get fellows and faculty practicing, overcoming those early days when people are reluctant to try a new skill?
I think that's a hard one, because I think especially in a busy unit, right, people tend to fall back on what they know best. So unfortunately, in some instances, it's a little bit of putting folks on the spot, or, like leading them to it, right? I've definitely done that where I've heard of a procedure happening or heard of something happening in the unit, being like, hey, that'd be great for what we just learned in POCUS. Let's go do it together. So certainly there's a lot of that, but I know staff has done some really innovative things in terms of using social media in terms of getting her learners to get more involved in POCUS too. So I think I love that part of the presentation, Steph. I thought that was very interesting what you've done there.
Thanks. Yep, we do a lot of, the text messages have been a great addition. The one thing I learned from them are there are not a lot of cases in neonatology that you can really drive into them, and trying to determine best time for them to happen. So we've actually been on a little bit of a break from them and restarting in the next week or two. But in terms of getting people active in the unit and doing it, it really is just a lot of hand holding for us, and like, hey, look, here's a machine, let's go do it for this procedure. And some fellows will really pick up on it a lot more than others, and will go on their own and do the procedure once they, and ask for your help, of course.
But this definitely will change it, or is changing already over time, right? So definitely the fellows or the younger faculty are the more enthusiastic about using point of care ultrasound, for sure. And as Karina said, like the older people don't want to just go back and learn something different when they already know their way and it works. But what I see is that since this is already being taught in medical school, like medical students are already trying or expecting to practice this, right? So definitely it's just evolving, and it's going to change within like very few years, and it's going to move towards doing this very, very often. I mean, everyone in the unit, I think.
Honestly, it starts with just someone being interested in ultrasound and having this curiosity in the unit. The more that you bring the ultrasound machine out with you and do things, the more that nurses, staff will recognize that there's a utility to it, and they'll call you over and then start using it themselves. So certainly had more interest as they see the machine more. And if you don't know what you're looking at, that's where, having these images saved and then asking some of the partners that are within the hospital, and you end up learning more and wanting to do more, and that brings it out with others as well.
Totally agree, Shazia. Visibility, right? Bringing that machine out there, using it, putting your machine someplace where it's really accessible for people to use it, to see it all the time, so that they, get that little prompt. Oh, hey, there's another tool in my toolbox.
Marshall, how did you get initial buy-in to start your text-based training program at Lurie?
Oh, I just told the group that we're going to start a text-based case presentation just to try it out. And it worked well the first few times. There was a lot of participation. There's a few times when you're sitting there and there's crickets, but overall there is a lot of participation. So it was more of a, hey, we're going to try out this new thing to see if this works for image interpretation and just getting the idea of ultrasound out there.
Our next question is, do you feel that POCUS can generally be viewed as an extension of the physical exam, or do you feel that to ultrasound babies, you need specific parental consent for POCUS? So is consent always required for POCUS, or is it an extension of the physical exam?
For a clinically indicated POCUS, I would never ask for specific parental consent, in the same way as I wouldn't ask if I need to do if I'm clear that anything is required. If it's a training indication, we currently personally get verbal consent from parents to check if they'd be okay for us to do a non-clinically indicated exam. I'm not sure which of those two questions you were asking.
Same for us. Like the babies that we admit, I usually do a clinically focused exam based on why they're admitted. But the sessions where the fellows come to the bedside or Dr. Horowitz comes to our bedside, I verbally talk with the parents either at the bedside or on the phone to get their permission.
What are the top 2 to 3 skills to start your curriculum with if you are starting a new program?
I think that it's always easier to start with a procedural ultrasound. That's where if you have to just choose something, I would personally choose that, you know, PIV, PAL, and PICC line placement initially to start with vascular access.
I agree with that, unless you happen to have somebody in their related team that's got a particular area of expertise somewhere else. But yeah, we're having paused a little bit here. We're trying to reinvigorate our training with a specific focus on vascular access. We have this nice 2mm vessel size task trainer, which is super cheap and super easy. We have a 1mm that's actually really very hard to put a PIV in, ultrasound guided. And we have a nice new machine that gives us a very, very crisp image quality for that. We're training our nurses as well as our nurse practitioners, as well as our fellows and our attendings for that. We would like everybody to feel ready to use ultrasound for vascular access. And once you've got that getting over that first hurdle of people wheeling out the machine and turning it on and knowing where the buttons are is a really big hurdle for people. And I think the frustration of, hey, nobody can get a PIV or a PAL into this baby is such a clear driver for us to say, let's try something else. I think that will be a nice way. I would rely on Shazzy or Mackie or somebody else to tell me what percentage of their providers they've actually got using that in a day-to-day. We're still at a very low percentage here in Austin.
I think the only thing I would add to that is to agree with the line placement, and some of our fellows have gotten really great with putting in art lines and ultrasound guidance. We started initially years ago with UV lines, mainly because we wanted to just get people used to looking at something and not necessarily having to do it from a procedural standpoint, but just to get used to having a machine and utilizing it. And that certainly we had a lot of patients that have UV lines, and we know that it moves a lot. So we did start early on with that just to be able to get in the unit more and to be more regular in the unit. And that helped with the visibility standpoint as well.
For those of us starting to learn POCUS ourselves, what benchmarks do you recommend using to determine when the faculty is trained enough to teach and evaluate fellows?
I think that's a really hard question to answer.
Go ahead, Karina.
Right? That's a hard question to answer.
I think you know it when you see it.
There you go. Yeah, but I mean, I think it also comes back to the see one, do one, teach one, right? Like part of learning is teaching too. So I think the teaching, I think that, like I said, is really an important part to learning. So I would think that you would need somebody that has like overall umbrella oversight over your trainers, especially if you're going with a train the trainer kind of a model for the program. But that's a good question, hard question to answer.
And I think for many of these things, you know, when are people ready to scan? When are people ready to teach? We're trying to push a binary assessment outcome onto what's very much a continuous pattern. And I feel okay trying to do peripheral access at the minute, but I wouldn't be terribly comfortable trying to teach others how to do it. But there are other areas where I absolutely would. So I think it's a continuous measure, and it's one part of a complex system. And so long as we are getting decent numbers of scans through, saving the images for quality review afterwards, not practicing in isolation, having us all look after each other in terms of our scanning, I think you gradually move forwards rather than being an aha moment where suddenly you're ready. I don't think that ever happens.
You know, we document on our red cap also if there's a supervisor and who the supervisor is that's doing the ultrasound with you. So we have that information as availability for potential looking at for QI assessment later. But it's a great question to know when you yourself feel comfortable with teaching. It may be well more than 25, or it may be less, depending on how you feel confidence and how you do image review.
All right, our next question is, how do you bring standardization to the training provided?
Also a very good question. I mean, I think to a degree, standardization is inherent when you have a limited number of trainers, right? We tend to teach relatively similarly to how we have taught in the past, although hopefully I would hope that our skills do continue to evolve. But I think also having steps like the mini checks that Alan was talking about, that I think that is an excellent way to bring standardization to any kind of a training situation, regardless of whether it's POCUS or any other skill-based learning. So I think that is an excellent way to do it. So boiling it down to steps and making sure your learners do those basic steps.
And there's certainly programs that have protocols for each image. I know Alan has some really nice ones that is put together for how to obtain, what to obtain for the images. There's some models in the adult literature as well on how to acquire the images and how to interpret. So going by protocol assessment may be a way to standardize as well.
And I did put a link in the chat to our online POCUS resource on OneDrive, where we've got a lot of the repository of a lot of these different tools for you guys. So if you guys are interested in looking at that, you can check that out too.
All right, we probably have time for one more question. Why do you think the development of POCUS programs and regular use of POCUS in the NICU is behind other fields like PICU and PEDS emergency medicine?
You know, I always feel like the tiny patients get the trickle-down effect from the big patients, but that's probably an oversimplified answer. I think some of it has to do with technology and the advances there, and being able to see smaller things with better clarity on newer ultrasound machines. But I do think I think that's kind of the hallmark of PEDS, is that we're really on the back end of what has the innovations that have been done in adult medicine, unfortunately, for certain technology-based things. So.
I think it's an interesting question, but we are where we are now. And so now that we have the interest already here, Maggie and colleagues put together that AAP guidelines and technical report that came out that hopefully help move this forward. So maybe we'll be one of the slower ones, maybe we can be one of the faster ones to implement and get off the ground. So it's a good question. I don't know if anyone else has an answer to why we may have been slower than the technology being not quite there, even though some of the probes are still being instrumented for some of the other machines to be better for our younger kids, but certainly we can move forward quicker.
I think the concern of missed structural congenital heart disease has quite rightly slowed the implementation of hemodynamic assessments. I'm not surprised by that, but I don't think it needs to anymore. And I think for us, the AAP position statement that came out last month, I know Mackie had a big role in that. Thank you, Mackie, for doing that. I think that's really going to take away some of the concerns and provide a roadmap for how we do this, provide legitimacy. I feel we've reached the critical mass now where it's more of a risk to not have a POCUS program than it is to do POCUS. And I hope we'll find from that those who are not doing it because of the concerns of risk will start to see that that's not a logical argument. But I think that risk of misdiagnosis is entirely valid, but is manageable.
Well, thank you everybody so much. On behalf of the planning committee, we want to say thank you to everyone for joining us today for the second webinar in our series. And we do have a link in for a brief survey. If you could fill that out, we'd really appreciate it to help us guide our next webinar to meet everyone's learning needs. And as a quick last plug, a lot of the members on this expert panel are going to be hosting a workshop at PAS. So we hope to see you there. Thanks, everybody.